Slides and
Yes, Karan, do you want to share your slides to ensure that everything is working well?
Sure. Can everybody see this?
Yes,
perfect.
fantastic, great,
Great.
awesome. Okay,
Perfect.
so
Yep.
maybe I can start with my slide, and Professor Armstrong, maybe you can then introduce your
Happy
speaker.
to do it.
So, Karan, do you want to stop sharing your slide? So I can create my slide. Here you go. Okay.
Wow, nicely done.
So let's start. I know that it's a new link. Hopefully that giving enough time for people to figure out this new link and join us. As I said today, also we'll have a stream on LinkedIn. So hopefully those who are missing can watch online as well. And we are recording the talk for the members who may miss this talk. This talk is it's very interesting. Actually, it's very relevant to the actually topic of my research and the scope of citizenship. Definitely we are looking forward to learn from One Line Health. Karan, I hope that you use the right logo, but I look at actually the website. It's very impressive what you're doing. And of course, Dr. Armstrong later on will introduce the team, but this is something that I believe that it's shaped as a part of the USC, and then it's formed to a company. But before starting, for those who are new, I would like to give a general overview that what is C2SHIP is about and what is our mission and focus. So basically, C2SHIP or Center to Stream Health Care in place. The mission is to bring care to any location where patient is comfortable to receive care. This is a mission that we have, and we believe that is achievable. And to achieve that, definitely we need to build partnership, interdisciplinary partnership, and also we need to really leverage the expertise from multiple institutions and university to help our industry to advance this field forward. And for doing that, thanks to a grant from National Science Foundation, Industry University, Collaborative Research Centers, we achieved to united 6 academic institutions, including University of Arizona, Baylor College of Medicine, that will soon become UCLA, University of Southern California, Caltech, University of Missouri, and University of North Dakota. And the idea is to leverage the infrastructure, expertise, talent, IP, and resources that we have among these 6 academic institutions and beyond to create infrastructure for industries who wish to advance their field forward. We providing the service to them, and we help to execute their projects. We are grateful that we have over 21 industry that join our infrastructures, and those industry that are representing by 2 industrial chair and co-chair advisory board member, chair and co-chair, including Margaret and Naomi from Medline and Best Buy. The way that the center is operated is that industry articulate the needs that they have, not university. Of course, university can pitch the idea to industries and say that this idea has a viable commercial aspect, but usually the project that we are doing is reverse. Industry saying that these are the needs that they have, and university trying to find a solution for them, leveraging their infrastructures. If you know any industrial members that are interested about these infrastructure, please connect us, and we will explain the benefit that this center can provide to them. I will skip that one, but this program of IUCRC, or Industry University Cooperative Research Centers program, was one of the most successful center that NSF formed back to 1970, and it still survive because it's provided great values to all the stakeholders, including industry, university, and government. So the hope that we have with these amazing combination of skills from university, from engineering, clinical resources, entrepreneurship, etc., is to help industry and also help overall our healthcare to have an add-on. I emphasize we don't want to change the hospital setting, but we would like to have an add-on to improve access to care. And this add-on to our healthcare model, that's called the centralization of healthcare model, is a patient centers. We call it care in place, that help patients receive care no matter where they are. and manage your chronic condition, acute condition, and more. This is a huge need. You probably hear about the news about the health equity is a huge topic, and there is a reason for that because currently your healthcare system is expensive, and one of the reasons that is expensive is poor access to care, patient not receiving the timely care, causing more problems to our healthcare system. The recent statistics suggest that this costs our healthcare system over $93 billion in exceeds medical care costs. In addition, we have many indirect costs, including loss of productivity per year and many more. But the good news is that healthcare leaders, finally, they got it and trying to make a change. So that's why the timing for our C2ship and this partnership is perfect. This is a statistic from Philips, among many others, that suggests that 40% of hospitals expected to have shifted 20% of their beds to patient homes by 2025. And you're hearing today from our speaker that we are seeing some of the technology that helps to contribute to that mission and more. The way that they build this center, and actually what I'm hearing is that currently we have the largest IUCRC in the nation with 6 academic institutions and many industry members that we have, but our competency is centered on 3 areas. Design, we have amazing engineers that they know the next generation of wearable technology, tattoo sensor, the embedded sensor on the body and on the body, and many more. Others are expert in stream data, data fabric, and we have amazing clinician, hospital infrastructures, and many more to facilitate prototype testing, designing clinical trial, and also doing the bed-to-bench research. And the project that we are actually strategically supporting and promoting and industrial members that we have that are supporting those projects are focusing on 4 areas, including prototype design, data fabric, decentralization of clinical trial, navigation post-hospital, and acute care and chronic management and home care. The values is significant from partnership building network, training, and also direct research impact. I just limit to that. Numbers came from NSF that $1 investment of the center by industry members, the return investment is $33, and that is significant. So at the same time, we would like to highlight that C2ship is not focused on early stage research, is not focusing on commercial deployment, is really bridge a gap between these two, is improving technology readiness. These are the projects that we are supporting through our C2ship. And I'm so grateful and also very proud to announce that at least 18 industrial members contribute to that mission, the sponsor, the mentor project as part of our C2ship. And we're hoping to expand that with the support that we have here and also the great talent that we have as a part of our C2ship. There are many success stories. I keep that. We have some industry members that have a cool technology that would like to get a new FDA label for the new condition that we have. We achieved this one, and they are now negotiating to get this new FDA for long COVID. We have a technology like Best Buy Health that is trying to improve the technology to address the loneliness, prevent fall, and also promoting aging in place. Is successfully progressing. Now we are deploying their commercial system and engaging residents, pre-med students to benefit from those projects as well. And they get also good benefits. We have also partnership from also multiple institutes, industries like Signify and Best Buy that lead to great impact. We have technology that it now start to be commercially deployed actually in St. Luke's Hospital to help to improve communication between patient and care providers after oncology surgery. And also we are partnering with industry to submit large grant to help our smaller business as well. Like this ARPA Edge that led by University of North Dakota, engaging a couple of industry members to build them. And this is the part that I would like to stop and think about it. The value of partnership, that it's make a huge impact for both academia and in industries, because we have a stronger voice, we have a better visibility, and we can tackle a bigger problem by building that network. So please note in your agenda, very soon we'll celebrate our fourth annual meeting in North Dakota, hosted by our latest academic site that joined C2SHIP University of North Dakota at Grand Forks. During annual meeting, for those who are not familiar, this meeting that is a hybrid, but we highly encourage people to attend in person because it's a great opportunity for networking, for students to connect industry, for industry to connect to other industries. That's also with academic side building more partnership. And during that meeting, usually we are giving a report about the project that were mentored and sponsored by C2SHIP and by our industrial members. Additionally, we are pitching new project in line of interest of our industrial members, in particular also new industrial members, that the faculty pitch the ideas, or industry and faculty together, they pitch the ideas, and those projects have a chance to be selected and become a formal project sponsored by C2SHIP. So it's a great opportunity. It's a great celebration to celebrate many achievements that we have. So please note in our agenda and attend in North Dakota. I've never been North Dakota. I'm very excited actually to go to North Dakota and also seeing amazing resources that we have here. The agenda, I believe that soon will be shared and also improving. So of course, I'm guessing that Kuyar, I missed something and I saw a text. Please, if I missed something, please go ahead and maybe briefly explain about the annual meeting. Oh, Kuyar,
I am in Buenos Aires airport on my way back to US. Sorry, cannot talk much. But looking forward to have you all in North Dakota. We are preparing a good plan for those days. We also have today Satish from Predict joining us in this meeting, and he's going to join us for the annual meeting. Looking forward to have you all.
Awesome. Thank you so much. And the meeting.
I don't think you knew that. I'm sorry to interrupt, but I don't know if you know that that Grand Forks, North Dakota's sister city on the southern hemisphere is Buenos Aires, and they both are tango capitals of their respective regions. It's fascinating and really little known fact, but there you go. Kuyar, our tango science engineering ambassador.
I wish.
It's amazing. And please note that also after C2SHIP annual meeting, there's one day we have also next Bioscience Summit as a great meeting. I'm honored also to be part of that meeting as well. You can extend your stay there and attending to that summit as well. So with that introduction, Professor Armstrong, the platform is yours to introduce our great speakers today.
Yes, well, it's great to see everyone, and as always, and even on the new link, boy, after all these years, old and new faces. But a few months ago, I was at dinner with Professor Indy Gill. For those of you who don't know about Professor Gill, he's a distinguished professor here, and has made our Department of Urology really the world leader, not only in clinical care, but in research and innovation. I mean, he is, as a toe doctor, to see who has always thought of myself as an early adopter, to see Professor Gill doing it, man, it's next level. And he has embraced many areas in surgery and in medicine, from additive manufacturing to AI to just virtual care early on. His son is no exception, and he had told me that his son had, as a medical student and as a undergrad, had come up with a really elegant idea of maybe capturing information from the patient, something that often the patient does, that we do just when we're doing an intake, that would not burden the patient or burden the doctor, and also capture this information in an elegant manner that could really begin sort of paying it forward using kind of natural language. And it is the perfect kind of setup for much of the work that we're doing here with the Center to Stream Healthcare in Place, C2SHIP, to maximize sort of hospital-free activity-rich days. And I think there's all kinds of potential applications and synergies. But ladies and gentlemen, will you please help me welcome Karan Gill.
Hi, everybody. Thank you so much, Dr. Armstrong, for the very kind introduction. And thank you, Dr. Najafi, as well, for the very kind invitation to speak here today. Very excited to share with you our work with OneLine Health, and I'll just get right into it. So at OneLine, we've created pretty much an AI physician co-pilot to conduct autonomous outpatient clinical support, as Dr. Armstrong was alluding to. The main mechanisms in which we're doing that is twofold, both in the preclinic and the intraclinic space. Firstly, in the preclinic space, we have automated several things that stemming from the detailed history taking or subjective data collection that physicians do on a daily basis during patient interviews. The second is extraction of laboratory imaging or other medical study results, or the objective data that physicians are tasked with manually combing through. And then the third would be complex data analytics. So putting all of those findings into, trends, graphs, schematics as appropriate to make things more digestible and understandable for the physician, and have all the information that they need at their fingertips, and cumulatively summarizing that into a clinical note for the provider to review that's of the highest quality, yet with no work having been done on their part. For the during consult or intra-consult space, we have an ambient scribing or voice-to-text interface as well that we'll dive into a little bit more. But just laying out all of our comprehensive value adds, whether it's before, during, after, or in between patient visits. As I mentioned before, we're doing a lot of clinical data aggregation and summarization, as well as some ancillary benefits. During visits, we're able to facilitate clinical decision support for the physician, as well as that ambient documentation as well. After visits, enabling, better patient education, setting them home with personalized materials from the provider that they just saw or will see going forward, and then facilitating follow-up care as well. So having our hand in each different time point during a patient's healthcare journey really creates an end-to-end solution that we're able to support both the physician and the provider and the patient holistically. This is just a brief list of some of the significant engagements, partnerships that we either have worked with in the past or are continuing to work with. And so essentially how it works from a workflow perspective is a patient will be scheduled for an appointment in advance and automatically be filtered to their OneLine AI pre-screening before their appointment. That patient would engage with their pre-screening AI agent, and that agent would then conduct all of the necessary subjective history taking that an expert physician in any medical discipline would do otherwise face-to-face. And we're able to process any patient presenting complaint and gather the necessary history that, as I mentioned, an expert physician in that space would need to know in order to effectively have a conversation with that patient about management and next steps. So that AI agent would be able to conduct that entire process, as well as summarize the output of that into a clinical note for the physician to review, and also supplement it with the appropriate labs, imaging, any other ancillary information that may be available in the EMR for the physician on their behalf. So in the aggregate, decreasing physicians' mundane, repetitive work that's involved with seeing, a busy outpatient clinic, increasing physician and patient satisfaction, saving time on both the physician and patient side, but particularly for the physician, 7 to 10 minutes per consult, which equates to about 2 hours per clinic. And in that 2 hours, we're realizing new revenue for the physician and the hospital system as a whole. So I'll just give you a brief video look into the interpersonal patient interaction that they would experience for a simulated case of a urology complaint.
Hello, I'm Daniel Park. Welcome to our urology clinic. Please fill out the special electronic questionnaire. This is very important to us. This will give us details of your urologic and other health issues, which will help us take excellent personal care of you. Thank you, and we look forward to seeing you very soon.
Hello, what's your first name? Great to meet you, John. And your last name? Okay, I'll remember that, John Doe.
Okay, now in your own words, please tell us what is the main issue that brings you to our clinic.
So, John, what is the reason for your visit? Include relevant information such as anything you've been told by other physicians and any tests, treatments you've had. Do you have any other specific details to share or additional concerns you would like addressed? Please share the details you'd like your provider to address.
Next, we have some specific questions about your urologic problem.
Okay, let's move on. Select all urological issues you've experienced in the past 6 months. Have you seen blood in your urine? Were you told there was blood on your urine test? Has a doctor told you the reason why you have blood in your urine? In total, how many episodes have you had blood in your urine? How often do you have blood in the urine? When does the blood occur during urination? Do you have blood clots in the urine? What color is your urine currently? What shape are your blood clots? Does your blood in urine have any relationship with your diet? Are you a current past smoker or user of tobacco products? Have you had any injury/trauma to the groin area? Have you ever had a urinary tract infection, UTI? Which of the following best applied to you? Select all that apply. Do you have pain in any of the following places? Select all that apply. Do you get blood in your urine when you exercise?
Now, we move on to general questions about your overall health and well-being.
Now I will ask some general health-related questions.
Okay, terrific. Now we are all done with our questions. Thank you for your time. This will really help us prepare for your face-to-face meeting with our team. Now, please upload any outside test results, lab results, scans, etc. you might have. You can do this by your phone, fax, scan, or email. We can call our office to help you do that. Thanks again, and see you soon.
Thanks for answering my questions.
So that was just a simple hematuria instance, but just to express the point that we're able to mirror the same line of questioning that an expert physician would in any medical discipline for any presenting complaint that a patient may have. And so now I'll take you through an example of the physician aspect, so what they can expect to receive on their end. Can everybody still see this?
Yes.
Yes.
Okay. So this is an
Looks
actual.
great, Karen. It looks absolutely great. And you're
Thank
doing great, man. This is freaking awesome.
Thank you, Dr. Armstrong. This is an actual patient note that was generated at one of our sites in Orange County. It's been fully anonymized, but just to make the point that this is an actual patient that was seen using our technology. Everything that you'll see on this page has been fully automated. There's been no human intervention whatsoever from the physician side. So I'll just take you through it one by one. From the very beginning, we have just a brief summary as to who this patient is and why they're here to see their urologist or any medical provider for today. In this case, it's a 72-year-old male restaurant owner presenting evaluation of prostate cancer and erectile dysfunction. We capture the chief complaint and history of present illness in the patient's own narrative in the same way that a physician would face-to-face, but just understanding, verbatim from the patient's perspective, the issues as they see them. And then we get into the summarization that our AI agent is able to make for each, for each presenting complaint that the patient has. So in this case, he's coming in with prostate cancer, erectile dysfunction, and some lower urinary tract symptoms as well. Typically patients come with not just one or two issues, but 5, 6, 7 plus things, and which is quite challenging to resolve in a quick 15-20 minute consult. So our platform is able to capture all of the necessary information to give the physician a holistic understanding of that patient's presentation, yet prioritizing it so that the physician knows what is of most importance for the patient during that encounter today. So, for this particular encounter, this patient wanted to discuss their prostate cancer and erectile dysfunction as indicated by the stars to signify their primary and secondary concerns. But for each symptom, regardless, we're presenting a fully positive history and negative history so that the physician has full confidence that a comprehensive history was taken and that there's really no further questions or information that's needed with regards to each symptom. And just to take you through one instance, such as the prostate cancer, collecting when the prostate cancer was initially diagnosed, their most recent PSA value and the date, when they had their most recent prostate biopsy, the fact that they had infection post-biopsy that required IV antibiotics. They've had some imaging done at this place at this date. They've had history of pelvic pain, bone pain, and weight loss, diverticulitis, hemorrhoids, further imaging, genomic testing, prior radiation, recent bone pain for the past year in their pelvic bone. But equally important is the negative history. So no incontinence, no UTI, no hematuria, dysuria, no chemotherapy, no family history of prostate cancer. And so with regards to prostate cancer, all of the subjective history has been consolidated and summarized here for the physician to review, and similarly has been done for erectile dysfunction and lower urinary tract symptoms as well. For those patients that qualify or meet the criteria for symptom assessment scores such as SHIM for erection status or urinary status with IPSS, those scores are available as well to give the physician, a more objective gauge on, the severity of their symptoms. And this obviously applies outside of urology as well. So any other fields of medicine that have associated scores such as, American Heart Association score or whatever the case may be, are also embedded within our platform so that, all the workup for a patient that could be done is done with our platform. As we continue, all of the necessary information that you would expect to see on a note. And then here we get into the data extraction component. So based off of, the fact that this patient has prior history of prostate cancer, our AI agent's able to automatically go into the EMR, pull out what's relevant for this patient's presentation. So serial measurements of this patient's PSA, with red dots indicating interventions that have been done and blue dots just indicating just PSA measurements, so that the physician can very easily see how a particular intervention has impacted this patient's PSA over the past 10, 12 years. And it's all consolidated in a very easily digestible schematic. So you don't have to go through, many individual documents trying to piece together what PSA measurements correspond with which, intervention, and then how it's trended over the past decade. That's all autonomously collated and summarized for the physician. For the patient's imaging that's been done for his prostate cancer, we have, our algorithms are able to extract what's relevant for the urologist to review. So in this case, this MRI of his prostate, here's the original report. It's been de-identified, obviously for HIPAA reasons, but just to give you the sense that for a urologist, we've extracted what's relevant for them to consider, which is namely the prostate dimensions as well as overall findings. Similarly has been done for their PET CT. For pathology, we have another interesting module wherein we're able to take a fully text document that looks at each of the 12 regions of a prostate, and all of the qualitative and quantitative analyses or findings that have been gathered for this patient, and distilling that down into a very easily digestible schematic. Again, easily visualizing the entire prostate and what areas are of most concern for the physician to, review and consider with medical or surgical management going forward. As we continue, to round out the note, we have national guidelines-based recommendations for each presenting complaint based off of what work has been done in the past with this patient and what is, gold standard national guidelines recommendations going forward. Certainly not things that the physician is beholden to, but just, considerations to make as, the physician is doing their own decision making. We also capture the overall comorbidity list and urologic problem list in association with the ICD-10 codes to capture medical complexity, and then facilitating CPT codes as well, so that it's not up to the physician to, guess what is the appropriate level of billing for this patient, perhaps leaving money on the table for the hospital system. All of that's taken care of as far as, time spent with the patient, medical complexity of decision making in order to optimize billing in that regard. So that is the pre-consult module that we have in order to extract patient history directly from the patient, labs imaging results from the EMR, consolidating that into a note for the physician to review beforehand. And then during consult, we have an ambient listening solution, which we're not going to go over today, but just, to briefly talk about it, would essentially listen into a consult and amend this note that you see here according to whatever conversation happens with the patient. So, a fully end-to-end solution where the physician has no burden or workload as far as documentation or chart review, chart prep, yet has all of the necessary information that they need from the patient. From the patient's perspective, there's significant benefits as far as providing that information beforehand, not having to, be under the gun during a patient interview or a consult, perhaps, not having their questions addressed, or forgetting to mention something, or not being able to make the most of their time with their provider. And so with this, we're able to, maximize the patient's perspective and the physician's perspective as well. As far as success metrics, this is just a brief snapshot into just some of them, but highlighting probably the most important would be patient compliance. So a question that we often get asked is, typically with, these sorts of patient engagement solutions, engagement is rather low in the 20 to 30%. Ours has been shown to be in the high 80s, low 90s, but consistent across many patient demographics, whether it's in a rural setting, an urban setting, private practice, large academic medical centers, East Coast, West Coast, Middle America, language or English being their primary language versus not, education agnostic. And so it's been, like I said, in the high 80s, low 90s, regardless of all of those factors. We have very high patient satisfaction as well as provider satisfaction. We've shown statistically improved clinical documentation using QNote methodology, which is a standardized tool used to assess accuracy and completeness of documentation for physicians' notes. As I mentioned before, around 2 hours saved per clinic with our solution, which equates to, new collections and revenue opportunities for the physician, in the excess of $40,000 to $80,000 per year per physician. And so, scaled across a large practice or a large medical center, those new opportunities for revenue significantly add up. And more recently, we've started a prospective randomized control trial at the University of Southern California. I will actually let Dr. Gill speak a little bit more to this, but yeah, we're very excited with the work that we've done so far and what we have planned going forward.
Thanks, Karan. So the data that Karan showed so far previously, albeit collected prospectively, was nevertheless single arm as part of a quality improvement initiative. And so therefore, while encouraging, certainly not reliable data because it's not prospective randomized. So now we are in the process of getting started with this prospective cluster randomized trial, looking at the impact of the novel technology versus standard of care, which is our current clinic practice. So the co-primary endpoints for this trial that is in front of the IRB as we speak is total work time. So at the end of the day, what does this technology do? It decreases physician work, yet provides an excellent clinical note. So we want to capture that right off the bat. So total work time, which has 3 subcomponents, which is work outside work, and the physicians on the call know, much of the work regarding pre-chart or post-clinic documentation is evenings and weekends, which is certainly not the way to live life and is the primary driver for burnout, which is affecting 50-60% of all physicians in the country. That's work outside work. Second is in-clinic non-consultation time. Third is consultation time. So I don't want to go into too much detail, but just to say that I think we've given it a lot of thought and put together the essential components that comprise the total work done by a physician for a patient. The second co-primary endpoint is the quality of the clinical consultation note using standardized Q note methodology, which is standardized and published, and basically takes your clinic note, breaks it up into 12 subcomponents, and then looked at by blinded observers comparing one note versus another. You can objectively score the clinical quality and diagnostic accuracy of the note. So these are the co-primary endpoints. Karan, next slide. And our secondary endpoints are the following: provider satisfaction by standardized surveys, patient satisfaction by standardized surveys, patient time to first clinical contact. I mean, currently, if somebody comes to see me, they're given an appointment 2 weeks out, 3 weeks out, et cetera, et cetera. For those 2-3 weeks, they're just sitting around, twiddling their thumbs, honestly, and getting antsy. This platform engages the patient right after the initial call. Right away, the link is sent to the patient and encouraged to get started working on it. Automated text reminders are sent every 48 hours in case the person has not started to fill it out. So patient time to first clinical contact is reduced dramatically. Referral wait days, we feel, will be, but we shall find out. That's the prospective trial going to figure it out. Patient in-clinic time, walk-in, walk-out time, provider productivity, how many patients are seen per clinic day, provider RVUs, a metric of work that the provider is doing daily, billing time from EHR finish to billing sign off, financial productivity. I mean, if we are seeing more patients or doing more work, here's hoping that more charges will be accrued, and so we are going to look at that. Eliminated false start first clinic visits. Half the time, patient just showing up, and then we look at them and say, okay, go get this test done, go get that test done, then come back. I mean, that's a completely wasted visit. I mean, why did the patient just come in, and why did he waste his time, he or she waste his time, and the physician waste theirs? This can be done in advance. And again, we are exploring that, and we'll be assessing it. Net promoter score, which is how the industry works on this stuff, and patients' compliance rate for the filling out of the AI platform. So these are some of the details that we hope to extract in our prospective randomized trial. Next. Okay, I guess that's it. And let's open it up for questions.
That is outstanding. That is great. This is your speaking citizenship language. This is what it's about. So without further ado, I would like to directly go to the question chat box. I have also myself many questions, but I wait to go first through the audience. So the first question, the chat box is from Michael. Michael, please go ahead. And if you'd like to chime in, I read your question. Can you disclose which models work on the back end and how you fine-tune, control them to make sure that the agents are staying in their lanes? And Michael, go ahead.
I actually later removed my question because I realized that you're not using the language models. You're using the scripted, multipass scripted, rule-based system. So my question becomes a little irrelevant. So it's fine.
Well, it's actually just to clarify, a combination of both. We do have a framework within which each AI agent is able to operate within. So, within the context of urology versus cardiology versus endocrinology, we have those rule-based frameworks based off of what symptoms are in line with that medical discipline. But we also have a large language model that's able to ingest the responses of those patients, understand how that ties back to their original complaint or what other ancillary symptoms they may or may not be experiencing, and then finding what is the appropriate labs, imaging results that need to be considered with this patient's presentation?
Yeah, I mean, just to give a little bit of framing around my question, I'm dealing with the problem of validating of the free running agents, like when they're in conversation with the patient. So the problem is, of course, how do you make sure that the agents are staying in their lanes? So because if there is a foundation model behind them, then it's easier for the patient to get them off the rails. And they will kind of, go and do whatever. So it's a difficult question of how to control the free running models, but that's the different technological framework basically.
Yeah, no, I understand your question, and you're absolutely right. We do have those rules-based framework in place to make sure that that agent stays within the context of that medical specialty that that patient is going to see.
Thank you.
Great. So we have a question from Arch about whether the information can go through voice mode. I mean, voice enable, and I saw with some of the studies that we are doing with our patients, sometimes they don't like text. They want to see voice and chatting. Is it in the agenda for this system?
Absolutely. And we're actually working on a really interesting use case wherein we have automated calls that are sent to patients where all of this interaction that was shown in the video is done over a phone call. We're able to record and capture that information and distill it down into a summary the same way that you saw with the patient interacting with it on their mobile or desktop device.
Okay, great. So another actually concept that we have, and we have Cheyenne from Silverberry that may chime in, one of our industry members, is that we realize that it's very important to have the relevant contents that also educate patient from some of the symptoms, and also ensuring that this content is flexible enough that the doctor that interact with patient also can include some more personalized content on those areas. So is it the area that you're working on? And I would like to engage Cheyenne in that dialogue as well, because I know that they have Pingo for creating some AI-based education to not bombard patient with the information that may not looking for. It's providing the information that they need to know, because the level of education for patient to patient is different, and level of information that right away they want to have access to, it might be different. Cheyenne, do you want to contribute on those areas? And maybe Karen, you can allude on those areas about personalization of the content to the patient.
Absolutely. First of all, congratulations on building the great platform. We have been working on this from outside. It looked like an overlap, but I see a lot of synergy than overlap or competition. I would love to meet with the team later. You are absolutely right, Bijan. What we have learned from interaction with the patients is that the biggest issue is in any education is I don't know what I don't know. And filling the gap that can be preventive and effective is the most important part. And of course, creating concise, at right time, right moment for the right question to the patient, that can go a long way, but it has to be supported with all the evidence, all the data interpretation from EMR and other doctor feedback. That really makes an informed piece of information to be effective for the patient. So this is fascinating, and I would love to have this conversation later with the team.
Thank you for the kind words, and absolutely. I guess just my two thoughts on the matter. As far as our support for patient education, if physicians, sorry, let me backtrack. Patient education is something that we don't feel is as robust of a offering as we would like it to be. That being said, we currently have the ability to send patient education materials if that particular physician has already created them themselves for particular, procedures or disease states that they want their patient to know either before they go see the physician or after their consultation. But an area that we're really interested in exploring is with our ambient listening is capturing, not just the clinical information, but the sentiment that the patient is expressing during that consult, and what questions, doubts that they may have, and sending them home with appropriate materials to follow up on after their consult, or even prompt them beforehand based off of whatever symptoms they're experiencing, and have them be more proactive in terms of knowing all that information, having it available to them, doing the necessary research before they go see their providers, so that they can have an even more informed and engaged conversation during the consult.
Absolutely. That has been our focus. Let's touch base after the call and
This is what we love. I mean, Citizenship is building partnership and really helping. We don't want to create the wheels. They have expertise on some areas, so if you can help and build partnership, that would be great. So Christy and other industry members, it asked how easy it is to go back or get to a person. Christy, do you want to elaborate on your question?
Well, I'm picturing myself interacting with the phone, and if I'm crabby that day and I entered something wrong, or I forgot to add to 5 questions back, the frustration level can go high very quickly. So how easy is it to go back and edit 5 questions back, or clarify something, or select operator, I want to talk to a person. How can you handle, it's kind of on that patient satisfaction standpoint. And then I had one other point to bring up from some of the customers that we've worked with. If you could make sure that your interaction is disability compliant completely, because there is a group out there, in particular in the state of New York, that their whole goal is they just scan all company websites, and then they sue you if you are not fully compliant to people with disabilities. So hopefully this is wildly successful, and the moment that it is, people are going to come after you. So those would be the 2 things. But yeah, because it's really exciting, and I think even my mom at 85 would use it. She has a smartphone.
Thank you for the forewarning. That's something that we're actively working on as well. To answer your first question about ease of navigation, so on mobile or desktop, it's very easy to just navigate back to a previous question and edit your response or amend it. In addition, after that entire encounter, something that we didn't show is that the patient actually receives a full summary of their responses in simple English, which they can then confirm and say, yes, all of this is true, or oh, okay, I forgot to mention this particular detail. So they have 2 opportunities actually to amend the document as they wish. That document is then the basis for what the physician receives, but everything is translated into medical terminology as they would expect. So the patient is never exposed to terms like hematuria, dysuria, things like that. They're seeing blood in their urine, or pain with urination, difficulty with urination, but the physician is, seeing the appropriate medical terminology on their end. So from a usability perspective, there's no medical jargon anywhere. We've been very conscious to make that be the case, and be usable by all age ranges, and accessible in every language as well.
And in your metrics, is privacy and their comfort level with privacy? Because I could foresee elderly not telling their own kids what they're feeling because it's embarrassing. My mom is so paranoid about clicking on things because she's sure everything is a scam. We've warned her well. So is there like a reassurance of that your answers are safe with us? This would be just like you'd be in a clinic's office, especially as you're getting deeper into what's really going on. Because that gets, the privacy of a doctor's office, you feel very safe for the most part.
Yeah, so one thing that we do that's really helpful in mitigating that is working with whatever institution that we're integrating with, and having it be a seamless experience from that side. So the patient never feels that they're going to some third party. Their experience for the most part is, let's use the example of USC. They're interacting with USC the entire time, so they don't have to worry about, trusting a third party. USC is some place that they've been to before, that they're familiar with. Their entire intake is with USC providers, with USC support, or whatever the analogous scenario would be for a patient in another medical system. So there's no alarming, areas of distrust, if that makes sense.
Because I think one area that could benefit is our Native American community, in particular rural, where if you had the right interface and that trust established, that would be really exciting. And I don't know what you would modify for something like that, but it could be very, I don't know, in particular for our Native Americans.
Absolutely.
Christy, I just want to, let me just say a couple. I just want to, Christy, thank you for really insightful comments. As regards disability.
Well, actually, do you want to repeat that I gave such insightful comments for
one more time? For the press, in the press gallery, we just want to formally, on behalf of Dr. Najafi and Dr. Armstrong, certify that Christy Jane is the cat's meow. How about that? Okay, but
okay.
Yeah, your points are excellent. Disability compliance is something we've thought about, and we will now focus on it even more as regards the giving the patient the confidence about that this is, you're right. I mean, there are scams all around us. And how do we make sure folks are confident that this is not one of them? Certainly language in the AI intake engine, reassuring them is one thing. The second thing is regarding, as Karan mentioned, as soon as the patient hits submit, the sophisticated note comes to the EMR to the physician. A layperson summary of the patient, what the patient just entered, goes back to the patient. And they can read it and they can confirm that everything is as it ought to be. And if they say, oh, I messed up here, messed up there, they can fix it and correct it on the fly. Also regarding the American Indian or the minorities, this healthcare disparities, we really feel that this can be, of course, a study would need to be done to confirm that. But I mean, if they can sit at home and fill out much of the stuff, since this technology platform is invisible to the physician, it is completely, so the physician has, this platform standardizes the intake. So the minorities or the healthcare disparities, folks who are not currently that emboldened, could at home fill out a equally detailed note as would somebody who's not from the disparities aspect. And so we feel that it's already in various languages. I mean, we send out the link in English. It shows up on your end in Spanish or Portuguese or French or Arabic or whatever. And then you fill it out in your own language. Even the avatar speaks in your language. And then when the patient clicks submit, the note comes back to you in English, et cetera, et cetera. So those features are already built in.
On that note, sorry to interrupt, but man, that I wasn't going to be talking about this, but the C2 ship already have, I used to be at University of Arizona, and U of A is one of our sites, and we have 22 different Native American nations that we work with on the day-to-day within our Native American kind of community at U of A, University of Arizona. The University of North Dakota, also a member of C2 ship, has an equal number of folks that they're working with in the Native American community. I could envisage doing kind of an elegant potential project here with 10 million people in LA County, many of whom are part of a zip code lottery, and what kind of urologic or diabetes or vascular care they may be getting, as well as in a really rural community. That would be, I don't want to go off too much on a whole academic tangent, but that's a real pragmatic kind of way forward. And so to be continued on that. But Karan and Indy, I had a quick question, and I may have missed it in the actual talk, so I'm sorry prophylactically. But are there data on how much, on how often patients come in and how often their visit is inefficient, or they're partially wasted? In just like you mentioned, Indy, that someone comes in and maybe they need some sort of imaging beforehand, or some pre-visit labs. How often are there any data in the literature that show that maybe 25%, 30%? I bet you it's even higher than that. Patients.
So David, excellent question. We have done a pretty thorough literature review of stuff. Obviously, this is not this is not our main field.
No.
That said, we are learning by leaps and bounds. So I doubt that those data are there. We will redouble our efforts to look for them, but we feel good. Karan, if you could throw up the slide one more time, just the secondary endpoints. We feel really good, David, that this prospective trial will get into the nitty-gritty, into the details of what a clinic visit comprises, what it ought to be, what are the inefficiencies, more than has been available till date. I mean, I don't know of really any place that will talk about, for example, to straight to your question, it would be point number 10.
Yeah.
Point number 10, eliminated false start first clinic visits. Our guess is, since we are going to be deploying this with Optum now, and Optum is going to be turning open their floodgates, and we're going to get a ton of patients. Wow. We would be overrun. If every single patient referred showed up in clinic, we'd be overrun. We anticipate that about 20 to 30% of the referrals, we will really address them remotely without the patient coming in. Now, since we actually have the detailed history, without talking to the patient, we already have the detailed history, we will be able to say, sir, we've looked at this, and we feel you should get this, that, or the other test, and then we will line you up in the clinic. So the moment, that's the other concept we have introduced here, is the pre-check concept. Pre-check, meaning when the patient calls in with an appointment to get an appointment, he's not given an appointment right away. He's put in pre-check. Okay, now, and the patient is sent a text immediately saying, you are in pre-check.
Wow. Now
you have to fill out this link. And the sooner you fill out the link, the sooner we'll have your information, the sooner we will move you over to an appointment. So that's an incentive for the patient to get on the thing and get it done. And when the clinic note is constructed autonomously and it shows up on our end, we will have one PA, one physician, a remote team. Every day they'll have a pre-check hour. So all the patients whose notes have been completed the day prior will be assessed by this team during pre-check hour. Each patient will take no more than 5 minutes, 3 minutes, whatever, and we will be able to quickly decipher these are the additional tests that need to be done for that patient. Those notations will be made, and someone from our team will get back to the patient literally in the next day or two to say, we've looked at everything, we understand your issues, we'll reconfirm briefly on the phone and say, please get these tests done, and you are in. We will get to check you out.
Excellent point. So again, we are so grateful to have amazing people in the panel, including the people like Christy, who has a great entrepreneurship experience and saw some of the challenges in the scalability of the technology, and also great comment from Dr. Armstrong. But I would like to piggyback on that questions and coming back to your primary and secondary endpoints, a very smart selection of the endpoints. It's something that the hospital they are looking for, but I was wondering that whether that can capture the patient acceptability, and I was wondering that whether you did that patient acceptability before running to that randomized controlled trial. For instance, I'm saying that you have patient satisfaction, but those are based on the survey for actual visit to the hospital, like communication with the nurses, how they interact with them, how easy they follow up with them. Those are important, but is not capture what we are considering for the digital health app for using at home without support, like the model that we have, like technology acceptance model, that they look at the ease of use or perceived ease of use that may not be captured on the press scanning or CG CAP survey, or the privacy concern, technology anxiety. We are using technology, and many people just talking about technology, just talking an app on the cell phone, simply you increase the anxiety and may not be captured by the patient satisfaction. And other metrics that usually we are using is that how often they're interacting in an app and for how long they're staying in the app. Could you please elaborate on this one? And have you done those kind of feasibility study before running in the randomized control trial?
Okay, so to summarize your question number one is, what is the patient, I thought you said, what is the patient acceptance of being enrolled in the prospective trial? Is that the question? One question?
No, I'm saying that is a kind of the feasibility of the study from point of view of patient. And because if the patient doesn't use the app, no matter what, that
as you said, and I should.
Yes, could you be able to, usually for digital app, we are recommending usability questionnaire and technology acceptance model from point of view of the patient, and was recommended that before deploying the
way is not very good.
Yeah, could you
He's just getting ready to go out on the dance floor right now.
Yeah, I'm not the host anymore, so I cannot mute the microphone, but the host can mute the microphone of Dr. Tavakkol. Here we go. Okay, awesome. So that was the question, that whether do we have those metrics from patient acceptability, engagement with the app, and how long they stay in the app, or is it something?
Yes, we do. So this point number 2, that is patient satisfaction press Ganey CG CAP survey, it is the adapted version of it. Okay, so it is not just what is standard being done, given to every patient showing up at USC. We have adapted it to our specific purposes, maintaining the general framework. But in addition, we have questions to the patient regarding, where did you fill out the survey? Not survey, where did you interact with the AI? Was it at home? Was it in the clinic? Was it on your phone? Was it on your laptop? Did you do it by yourself? Who helped you? Is it your family? Is it our scribe, et cetera, et cetera? As regards the technology aspect, we don't have, and you make an excellent point, we don't have a specific question about what did you think about the technology? We think that if they didn't like it, in the CG CAPS satisfaction survey, it'll come out loud and clear. We didn't like it, this thing sucked. The data that Karan has shown you is in the mid 90s or low 90s regarding patient satisfaction. So your point's a good one. If you feel, or if the general sentiment is putting in one question specifically from the technology perspective, we can absolutely do that. And I think we should do that, just to make sure that we address this issue proactively.
Awesome. Amazing talk. So we are running already the time. Excellent discussion and also excellent presentation. We are hoping that those kind of app can enter and improve the patient satisfaction, the access to care, and many challenges that we have in healthcare. Thank you, Karan. Thank you, Professor Gill, for
Dr. Najafi. Could we get the various questions that were put in the chat? Is it possible for us to get those?
Yes, usually since it's recorded, they can share the recording with you as well as the chat box. Again, Professor Roveda can facilitate these with you.
Yeah, definitely. Yeah, Dr. Gill, we definitely will provide the questions together with the recording. Yeah.
Excellent. Thank you, everyone.
Really
Happy
enjoyed
Friday,
it.
And see you all next Friday.
Yeah, thank you
Thank
very
you.
much.
Take care, you guys.
Strong, Dr.